Cubital tunnel syndrome. It is a compression of the ulnar nerve at the elbow region. It is not uncommon. It is the second most common nerve compression in the upper extremity after carpal tunnel syndrome. Anatomy of the ulnar nerve. The ulnar nerve originates from the medial cord of the brachial plexus. It runs down the arm where it passes under the medial epicondyle of the humerus. The ulnar nerve does not give any branches or innervations above the elbow. The ulnar nerve travels through a tunnel of tissue, cubital tunnel, that runs under the medial epicondyle. As the nerve passes behind the elbow, it may become compressed or irritated. The most common site of entrapment is between the two heads of the flexor carpi annaris, or at the aponeurosis of the flexor carpi annaris. As the ulnar nerve enters the anterior compartment, it gives innervation to the flexor carpi annaris and the medial half of the flexor digitorum profundus. Distally, the ulnar nerve supplies several muscles of the hand. During its course, the ulnar nerve can be pinched at different sites. Number 1, thoracic outlet syndrome. Number 2, cubital tunnel syndrome, which is compression of the ulnar nerve at the elbow. Number 3, ulnar tunnel syndrome, compression at Guyane Canal at the wrist. Causes of ulnar nerve entrapment around the cubital tunnel. Number 1, arcade of Struthers. It is different from the ligament of Struthers. The ligament of Struthers deal with the median nerve compression. If you find a medial bony process in the distal humerus, this might give you a median nerve compression, and the compression is at the ligament of Struthers. On the other hand, the arcade of Struthers is a hiatus in the medial intermuscular septum, and this will pinch the ulnar nerve. Another area of compression is the medial intermuscular septum. Another area of compression is the Osborne fascia or ligament. The ulnar nerve can be compressed between the Osborne ligament and the MCL. It can occur from deformity of the elbow, such as cubitus valgus, or the entrapment may occur due to a spare on the medial epicondyle. Other conditions that can show up in orthopedic examinations: one is elbow contracture release. You may want to release the ulnar nerve. If the patient has symptoms, the condition may worsen after you do elbow contracture release. Patient may get ulnar nerve symptoms many years after a fracture of the lateral condyle of the humerus, and non-union, which will give the patient cubitus valgus and ulnar nerve symptoms years later. What are the symptoms? The symptoms of cubital tunnel syndrome are worsened by performing activities that require bending of the elbow, which stretches the ulnar nerve. Straightening the elbow or extending the elbow will relax the nerve. Pressure on the nerve at the elbow can cause numbness or pain in the elbow, hand, wrist, or fingers. The patient will describe symptoms of pain and numbness in the elbow, as well as tingling in the ring and little fingers. The symptoms will get worse by excessive elbow flexion, such as excessive use of cell phone, or by sports activity that require a lot of elbow flexion. The patient may get night symptoms. More severe symptoms of cubital tunnel syndrome include weak or clumsy hand, weakness affecting the ring and little fingers, muscle wasting, such as the first interossei muscle wasting, claw hand deformity if compression occurs below the elbow. The claw hand in 4 and 5 fingers occur due to flexion of the fingers by a functional profundus muscle. Clinical examination: Tinel's sign at the elbow. Tapping technique is performed at the medial elbow over the nerve to test for symptoms of undernerve entrapment at the cubital tunnel. Elbow flexion test. Froment's sign. The thumb compensates to resist the pull on a paper by flexing the interphalangeal joint. It happens because the adductor muscles is weak. Also examine the patient for decreased sensation and clawing of the 4th and 5th fingers. Also look for wasting or atrophy of the first interosseous muscle. Differential diagnosis. C8 nerve root compression that can occur from a cervical spine disc. Thoracic outlet syndrome. The lower trunk of the brachial plexus passes in this space and can be compressed between the first rib and the clavicle and the scalene muscles. Another area is the Bancost tumor. It's an apical lung tumor. Treatment: conservative treatment with non-steroidal medications, elbow pads, physiotherapy, and possible injections. And night bracing in 45 degrees of extension with the forearm in neutral rotation. Surgery: simple release of the nerve with or without transposition. Type of transposition is controversial. Prognosis is bad if there is intrinsic muscle atrophy. Complication of surgery can occur, and the most common one is injury to the medial antebrachial cutaneous nerve. Neurolysis is not helpful. Thank you very much. I hope that was helpful.